Here is our quick roadmap for today. We're covering the Duke staging classification, stage-by-stage management, a key clinical pearl, a classic exam trap, and then we'll wrap it all up with a quick recall test.
Starting right off with Section 1, Duke's staging classification.
So while modern practice really leans heavily on the T&M system these days, Duke's is still an absolute classic. It's incredibly high yield and highly tested on the board, so you've got to know it. Let's break down these 4 distinct stages. In Duke's A, the tumor is strictly confined to the bowel wall. In Duke's B, the tumor extends through that bowel wall, but crucially, there is 0 regional lymph node metastasis. Duke's C is triggered the literal moment regional lymph node metastasis is present. And finally, Duke's D is characterized by distant metastasis. It's a very logical stepping stone kind of progression.
I actually love thinking about this anatomical progression like a clear visual staircase. We're moving step by step here, from the wall in step 1 to beyond the wall in step 2, into the lymph nodes in step 3, and finally, unfortunately, out to distant metastases in step 4. If you can keep this simple visual staircase in your head when you're reading through a lengthy clinical vignette, you'll save yourself so much time.
Moving right along to Section 2, Stage-by-Stage Management.
Okay, so now that we've mapped out the staging structure and understand that anatomical progression, let's look at how this directly drives our clinical decision-making. For Duke's A, where the tumor is confined entirely to the bowel wall, our primary weapon is curative surgical resection. That's the main treatment modality for sure. However, for some selected, very early lesions, you might just need a local endoscopic excision. That specific decision is completely dependent on the pathology and the exact depth of the lesion, but as a general rule for Stage A, we're thinking curative resection.
Now, stepping up to Duke's B, and remember, this is where it actually extends through the bowel wall, we have to step up our surgical approach too. We're now looking at an oncological surgical resection paired with an appropriate lymphadenectomy. This means we are surgically removing the associated lymph nodes for both regional control and sampling. And what about chemotherapy? Well, adjuvant chemotherapy here really depends on the modern T&M stage and whether or not there are high-risk pathological features present. It's not an automatic yes.
Now, Duke C is where things really shift. The second we have positive regional lymph nodes, the systemic risk goes way, way up. So the absolute crucial point for Duke C is that surgical resection plus adjuvant chemotherapy is generally required for colon cancer. The chemo is no longer a maybe based on risk features. It becomes a standard, integral part of the toolkit. And if we're dealing with rectal cancer specifically, you might even need neoadjuvant treatment, meaning we give the therapy before the surgery, depending on the exact stage and pelvic anatomy.
And finally, for Duke's D, where we unfortunately have distant metastasis, the entire management paradigm flips. Systemic therapy now takes center stage as the primary treatment. Surgery is no longer the default curative option here. Instead, we're reserving the scalpel mainly for managing severe complications, things like an acute bowel obstruction, a perforation, or severe bleeding. The only time we'd really consider surgery with curative intent in Duke's D is for highly selected, completely resectable metastatic disease.
Let's move into Section 3, Key Clinical Pearl. Let's just distill all of that staging and management data down into something you can easily digest. If you memorize nothing else, burn this high-yield cheat sheet into your brain right now. A is the bowel wall, B is beyond the bowel wall, C is nodes, and D is distant metastasis. It's really that simple. If you can just remember this ABCE breakdown, you're going to be perfectly oriented for almost any colorectal cancer exam question they throw at you.
Just to really hammer this concept home, because it's absolutely vital. The defining feature that immediately bumps a patient into Duke C is the presence of regional lymph node metastasis. It honestly doesn't even matter what the primary tumor is doing. The nodes dictate this stage.
Which brings us to Section 4, the classic exam trap.
Okay, pay super close attention here because board examiners absolutely love setting a trap right in this gray area. Do not confuse Duke's B and Duke's C. In Duke's B, the tumor has breached the muscular wall, but the nodes are completely negative. In Duke's C, the regional lymph nodes are positive. Here is the trap, right here. In Duke's C, those nodes are positive regardless of how far the primary tumor has invaded. Even if a primary tumor looks completely confined to the wall, if just one regional lymph node is positive, it is immediately a Duke C. Never ever let the depth of the primary tumor distract you from positive nodes when you're assigning the Duke stage.
Let's finish up with Section 5, a quick recall test.
All right, we've gone through the framework, the management, and the classic traps. Let's see if you can put this into practice on the fly. Here's your scenario. A colorectal tumor has invaded through the bowel wall and regional lymph nodes are positive, but there is no distant metastasis. What is the Duke's stage? Read that carefully, lock your answer in your head right now. Think about those defining features we just hammered home. Let's see if you successfully avoided the trap.
And it is Duke's C, for sure. Those positive regional lymph nodes instantly define the stage, completely trumping the wall invasion. Understanding that strict hierarchy is literally everything for this topic. That brings us to the end of our explainer. I'll leave you with one final thought. As modern practice shifts more and more to the TNM system, how will you use this classic, rapid-fire Duke's framework on the wards tomorrow to quickly communicate a patient's baseline risk? Thanks for hanging out with me, keep studying smart, and I'll see you in the next one.